All right, well, welcome back, everyone. So this is going to be our last part of our blood lecture. And so we left off in the previous part by looking at some of the clotting and coagulation process, right? So we left off by talking about the intrinsic pathway, the extrinsic pathway, and the common pathway. And again, those are all part of the coagulation phase of hemostasis. So last things I want to talk about here are continued blood loss. So again, what's happening as you lose blood, and then also when you are ready to remove the clot, or something called clot retraction, right? So just real quick here, depending on the amount of blood loss, our body will respond differently. So if we're losing greater than 10% of our blood, our sympathetic nervous system will increase. So again, this is part of our autonomic nervous system. So again, think about fight or flight type of response with sympathetic. So again, you get vasoconstriction, heart rate increases, force of the heart rate, and this is helping to maintain and keep blood flowing through the vascular system in response to blood loss. You can also have blood be redistributed to heart and brain, so again, keeping vital organs adequately perfused. And this helps to maintain blood pressure until you've lost a very significant amount of blood, right? Something like 40% of blood loss, right? So our body has a pretty good way of, pretty good ability to help maintain and keep blood pressure, keep perfusion relatively constant, even in the face of significant blood loss, right? So once you form the clot that we mentioned in our one of our last parts, one of our previous parts, you don't keep your clot forever, right? Obviously, and so one thing that you ultimately have is you have something called clot retraction. This is when essentially there are these kind of protein fibers. So this actinomycin will kind of cover the clot and squeeze the serum and make the clot smaller. And then you ultimately have the breakdown of the clot in a process called fibrinolysis, or you may see it called fibrinolysis, right? So fibrin is the fibrin that we talked about at the end of the common pathway, and then lysis means split, right? So here we're splitting or breaking down the fibrin, right? And so you do this through something called plasmin. There's a inactive form of it. It's called plasminogen. Again, the ogen, you know that it's inactive, and then it will be converted into plasmin through something called tissue plasminogen or tissue plasmin activator. And then this begins the process of breaking down the clot slowly over a number of days, right? Not immediately, because immediately you need the clot there. You need to ensure that the blood vessel is secure and no additional blood loss is going to occur. But over time, you'll need to break the clot down. Now, you can think about this also in a clinical setting in which you have a clot that you don't want, right? So think to yourself, when might you want a clot, when might you have a clot that you don't want, right? So a good example of this, think stroke, right? A stroke, there are different types of strokes, but one type of stroke is a thrombotic stroke, or a stroke in which you have formed a thrombus or a clot that has traveled to the brain and formed a blockage, right? It's caused a blockage. You could also have this cause a heart attack. It could cause a pulmonary embolism, right? There's several things that a clot could cause, but one of them is a stroke, right? So in this context, this is a clot that you do not want, right? And so trying to break down that clot is very important, right? And so if it is a thrombotic stroke, right, a stroke due to a clot, then in a clinical setting, and again, this is usually occurring within there's a timeline, but usually within a couple hours of the onset of symptoms of a stroke. In a clinical setting, you can give a medication called TPA, right? And the TPA is that tissue plasminogen activator, right? So essentially what that medication is doing is it is being introduced into the body. It is going to the plasminogen, activating it into plasmin, and then that plasmin is acting to dissolve and break down the clots, right? In that case, in the case of that stroke patient, that's a very good thing, right? Breaking down that clot to restore blood flow to a certain part of the brain, right? However, if you are if you have other clots elsewhere, if you've recently had a surgery and you have sutures, you have stitches, staples, something closing up a wound, and then you have a stroke and you give it, and that medication was given, you can imagine how you're also going to begin potentially bleeding at those incision sites, right? So there's considerations to give, right? Or considerations to make. Now, one other important thing is you would never give that tissue plasminogen activator. You never give TPA to a patient who's having a hemorrhagic stroke, right? So in other words, a stroke due to bleeding, right? Because if you gave them that and they're having a stroke due to bleeding, that's just going to make the bleeding worse, right? Because it's going to prevent clots, right? So it has to be given specifically to patients who have a clot, right? A stroke due to a clot, right? So there are various conditions that can lead to the formation of clots or the lack thereof, right? The inability to form clots, so imbalances leading to bleeding or clotting disorders. This can also result in be due to damaged blood vessels, impaired blood flow, atherosclerosis, vessel inflammation, lots of different things. And then you need your various nutrients, right? So you need calcium, you need vitamin K, all necessary to produce our different clotting factors and to be involved in this clotting process, right? And then, of course, there's medications that interrupt the clotting process at some point, right? So heparin, there's one called rivaroxaban, which, again, they're interrupting the clotting process at a certain point, maybe preventing the formation of factor 10. And so if you prevent the formation of factor 10, you ultimately prevent the formation of fibrin, thus you prevent the formation of the clot, right? So again, patients who have AFib, atrial fibrillation, patients who have recently had some type of maybe heart procedure to keep the blood thin, maybe they've had an angioplasty, maybe they've had a stent put in and they're on blood thinners. Again, these blood thinners, heparin, warfarin, things like that, are acting at some point in that clotting process to interrupt the clotting cascade, right? So a few conditions related to bleeding and to clotting. One of these is hemophilia, right? This is a very common one, right? So hemophilia is a bleeding disorder. Results in a increased rate of bleeding. There's two forms, hemophilia A, hemophilia B. A is the most common. The way you can remember this, and it's specifically due, hemophilia A is specifically due to factor 8. The way you can remember this is A880. Okay, they all kind of go together. Hemophilia A is a deficiency in factor 8, and it accounts for 80% of cases, right? A880, hemophilia A. In this case, males are typically they typically exhibit the disease, they have it, because this is what's called an X-linked recessive disorder, meaning that it's carried on the X chromosome. Biological males only have one X chromosome, so if they receive that recessive allele on the one X chromosome that they have, then they will show the disease. They'll have the full-blown disease. For females, because they have biological females have XX chromosome, then they may receive one recessive copy, but so long as they receive the normal copy for making factor 8, then they're fine. They'll be carriers for the disease, but they won't have the disease, right? So this is similar to like something like color blindness, right? Color blindness is X-linked recessive. So who do you know if you can think of somebody who's colorblind? They're probably male, right? Females can be colorblind. Females can have hemophilia A, but it's more common in males, right? So again, you're at an increased risk for bleeding. You can also have things like thrombocytopenia, again, platelet deficiency, again, potential risk for bleeding. And then, of course, different drugs that we mentioned just previously. Warfarin, ibuprofen, ginkgo can actually serve as, it can have some blood thinning, anticoagulant properties. Aspirin, things like that, right? All of those are helpful in thinning the blood for certain reasons, and then for other reasons, patients may not want them, right? So it depends on your case, right? And then you can have hypercoagulation, right? So in other words, instead of having the inability to form a clot here, now you are at an increased rate, or you have an increased rate of forming clots, so hypercoagulatory disorders, right? So maybe you have too many platelets. Maybe you have a certain condition. So again, something like atrial fibrillation. The atria in the heart kind of quivers and beats irregularly and rapidly, and so it causes blood to pool. Blood pools. It sits. When blood is not moving, it clots, and then ultimately those clots get ejected out of the heart into the lung. They go to the heart tissue itself. They go to the brain, and again, they cause a heart attack. They cause a pulmonary embolism. They cause a stroke, right? So in those types of patients, often they're on patients with AFib. They may be on some type of blood thinner, right? Some type of blood thinner to prevent that, right? So consider some of these questions. Last real thing that we're going to look at here again is just hematopoiesis in kind of across the lifespan, right? So again, hematopoiesis occurring in most bones in young children. In adults, it's reserved to bones in the axial skeleton. So again, think of what axial skeleton is from your AMP1 individuals. The reason it changes over time is because we have more red bone marrow replaced with fat, with yellow bone marrow, right, as we age. And so you have a decreased ability to synthesize blood cells. Some of it can revert back to red bone marrow in cases of severe anemia. And so again, this is why older individuals, because a lot of the red bone marrow has been replaced with fat, they're more likely to become anemic. You may have fewer leukocytes. This may result in certain types of leukemia becoming more common. Also, maybe just in general, increasing your risk of infection as well, right? So some things to consider, right? So we're going to stop here. This is our last part. Please reach out if you have any questions about anything related to blood, and I will see you in the next video.